not all of you guys, so nearly everybody, but not everybody. So I'm Stacey Cobb, I'm from Developmental Peds. And we're gonna be talking about ADHD today. I think what we're supposed to be focusing on though is treatment and management. So this is like a really big slide set that has everything kind of all the way through. So we're gonna go real fast for the first slides. Don't be alarmed. It's because we're trying to get to the evaluation and management stuff at the end. And I don't want to keep y'all here forever and bore you forever too. So, all right, if it will move through the slides. Here we go. Okay, so you have nothing to disclose, no conflicts of interest, but we will definitely be discussing the off-label use of medications. If you've rotated with this, you realize how much we live in off-label meds all the time. So here are the wider learning objectives, but today we're mostly going to be focusing on the ends, the last three objectives there. So like the differential diagnosis and common comorbidities, because those have a huge impact on your treatment plan. And then we'll talk about long-term outcomes of childhood ADHD, kind of the why do we treat ADHD? Why don't we just say, oh, some kids pay attention and some don't? And then lastly, we'll actually look at the treatment plan and treatment strategies for this. So we'll start with a case. So this is an 8-year-old. He's smart, but his grades are all falling. He can't really stay in his seat. This is what they come and tell you about in the well child check. He's forgetful, he doesn't really listen, and that's all they've got for you. And so you think, well, maybe this could be ADHD. What do we think? Does he kind of fit in the ADHD picture? Well, so ADHD is pretty common. So worldwide prevalence is around 7%. In America, it's like 8.5%. Developed nations are all a little bit higher than the developing nations. And so that's really where you get that kind of big split. And for a whole bunch of socioeconomic reasons is why ADHD gets diagnosed so differently in different countries.
Should we be able to hear anything?
Oh, we can hear you. Can you hear us? Yeah. Obviously not.
Stacey, I can hear you.
Oh, you can?
Yeah.
Okay. Who's
didn't want to listen to this lecture.
I know. Where do you know where he's at that can't hear us?
Dalton, where are you?
He's in clinic.
Can anybody else not hear her?
I can hear her in the NICU.
Clinic people, can you not hear her?
He said in the chat, is corn dog talking yet? So I'm guessing they can't hear her.
Oh.
If you just stand up and yell really loud.
Oh. Whitney, should I just go ahead? Are you working on it?
I'm working on it. Go ahead, Stace.
Okay. So there's this male predominant. So males are 2 times more likely to have ADHD, but that only applies to combined type. So we've got this like 8-year-old little boy. So he's kind of in the sweet spot for diagnosis and having these ADHD symptoms coming up. For inattentive type ADHD, it's a perfect 50-50 split. So there are no gender differences for inattentive type. And comorbidities are a little bit different, one group to the next. So ODD and conduct disorder are more likely in boys, where anxiety and depression are more likely in girls. But there's probably a huge diagnostic bias to that. So it's what you need to know for tests. We'll just real quickly look at the etiology of ADHD, which is really multifactorial. The important thing for you to know is it's heavily genetically predisposed. So of course our NICU babies, our TBI kids, they're also going to be at high risk for ADHD. Brain infection kids, so post-encephalitis kids, all at high risk for ADHD. But those are the unicorns of ADHD. That's not the like meat of the core of ADHD, which is mostly inherited ADHD. This is a complex slide, but I think it's interesting. So the bars are all these different recent studies, recent being used relatively loosely here. A whole bunch of studies looking at the prevalence and the inheritability of ADHD. And then the vertical lines are showing you where other medical disorders would fall in terms of how inheritable they are. So we always think of breast cancer and asthma being highly inheritable, right? And then you see how much further across the line, the red line of ADHD is. So ADHD is highly inheritable, almost as inherited as your height, which we all know how genetically predisposed your height is. So this has very heavy genetic loading. This kind of the thing to be thinking about. Many different areas of your brain involved in ADHD. That's what you need to know about this. And mostly there are two neurotransmitters involved in ADHD. It's dopamine and norepinephrine. But all of our medications work at dopamine receptors. So on exams, think dopamine first and norepinephrine second. Okay, they're usually coming after the dopamine component. And here are the dopamine receptors. We're skipping the slide. And looking at ADHD in terms of diagnosis, you guys know this. We've got 9 symptoms of inattention. You have to have at least 6. And hyperactivity and impulsivity, they're also 9 symptoms. You need to have at least 6, and they need to be seen with some frequency. So often to very often. ADHD subtypes. You can either have symptoms from both sets or one set only, or sets of both sets being equally expressed. With the caveats of that the symptoms have to be present in more than one location. You have to have onset of symptoms prior to 12, and you have to have clear evidence of impairment. And the symptoms can't be completely coming from another disorder. Sometimes you'll see us debating this in developmental peds about kids with autism spectrum disorder and whether it's really ADHD or not, and whether it's not coming from another disorder. And you'll hear us kind of go back and forth. That's more an academic conversation than in practicality. We're going to treat what we see, and we're going to treat it as ADHD. But sometimes kids will pop out of an ADHD diagnosis under this exclusion because their symptoms really are coming from something else more urgently in that moment. Here is our differential. So if that little 8-year-old boy presented, we have to be thinking with that really vague set of symptoms that parents gave. First of all, we haven't proven that he has symptoms in 2 locations yet. We just heard about it at home, really, from the parents. And then we have to think, could any of these be present? And most of these are unicorns, but we can usually rule these out pretty quickly with a decent history real quickly. This is a question that they love on your boards. love. So school failure, they're always trying to get you to think, is it ADHD? Is it a mood disorder? Is it some kind of trauma? Is it substance abuse? And many of you are nodding because you know I've talked about this exact thing with you so much that I put a whole slide in there for you to remind you about it. So this is the set of what you're kind of looking at. Organic disorders rarely would pop up on a test, but certainly we know if you're really hypothyroid, you're going to look kind of like you have ADHD. That's probably the only one on there that would probably pop up, but they're all good to know. This is the big differential of inattention and school failure, is this set of diagnoses. So we're going to go back to our kid with all this in mind. So social history is that he has trouble keeping friends. He's been kicked off his baseball team for fighting. But no big family stressors, no concern about abuse, no new friends hanging out, and mom found a pack of cigarettes somewhere. There's nothing like that in his history that would clue us to a different kind of part of the differential. Family history, oh, well, we have 2 older brothers with ADHD. That seems like that probably makes sense, right? With the prevalence and how inheritable we know this is. And then term birth, no issues with snoring, no sleep stuff. So we're starting to think, maybe this is just ADHD, right? So then we're going to use our fun Vanderbilt, y'all know and love. So we're going to cut to the chase and just see the results. So he had 8 symptoms of inattention. This is the parent form. 6 of hyperactivity and impulsivity. A total of 38, so a decently high number. And we had, in terms of the comorbidity screen, a few ODD, conduct disorder symptoms. That's what that 3 is on that line. No anxiety, depression, ODD symptoms, no conduct disorder, that would be the second line, and then the third line would be anxiety, depression. So pretty clean screen, although it sounds like it can be a lot of positional times. And then we had a number of 4s and 5s, which you remember is that's the severity score for how much impairment you have. So he's reasonably impaired. And so looks concerning for ADHD. So what would we need to do next? Yeah, we gotta get some teacher feedback. Ideally, this nice little tidy form, but any teacher feedback would do. So you don't have to have a teacher Vanderbilt. If they send a note with, if the teacher wrote a note to you and it confirms all the ADHD symptoms, you can use that. Just document what you used to get those from. Okay, so the teacher says, yeah, the grades are falling, everything's kind of going down. He's now below grade level in math and writing. There are no school supports, there's been no testing. He talks, he blurts out answers. So we see all these lovely ADHD symptoms. Is there anything that you guys would want to do other than getting this teacher Vanderbilt that says, yes, we see ADHD symptoms based on that history? Yeah, is there anything else you'd want before you said, yes, this is ADHD? So now you have parent and teacher questionnaires that both look like ADHD. What would you want?
I would do for the serum as well, just make sure he's on CPA.
Sure.
It seems like there's a bit of oppositional behavior at school as well. I would just make sure he doesn't have a little oppositional behavior. Moody kind of behaviors.
Yeah, so our Vanderbilt school scales should have triggered that. So we kept just underneath it on parents, and then teachers was probably in the same range. So yes, exactly. We're gonna keep our eyes open for that.
Make sure his hearing and vision are good.
Sure, yep. And the school should have already checked that, so you should actually have that documented nicely.
Has learning disabilities? I mean,
Yeah, so in a test situation, if they call out subjects like this, you want to go ahead and test those subjects, see if he doesn't have anything hiding too. So yeah, so we have several different kind of areas where we could work this kid up a little bit further and take a look. But the most common thing that you have would still be ADHD, which could easily pull down writing and math, which are both kind of heavy focus activities. So then our friend James, he's 8, so he provides some of his own history, and he says, yeah, I do have trouble paying attention. I definitely feel myself rushing through my work. He's sad, he's lost some friends because he's playing too rough and it's getting in his way. Normal physical and neurological exam, except for this little brief little eye twitch that he's got. So keep that in the back of your mind. Okay, so final considerations are we could do these other things. We could do some lab tests if we wanted to be super duper thorough. We could check his thyroid. We could check a lead and a crit. We're probably not going to do any of those things unless we had a real reason to check those. But those would all be logical parts of the ADHD workup. This is all coming from the AAP's current practice guidelines. So this is what they would ask you. Did you need these? They're not necessary, but if you had some reason to suspect. They were in an old house and they'd recently remodeled. You might should check that lead. If the kid only ever drinks milk, you might want to check a crit. So you've got, if there's any other history, you could lead down these other areas. Imaging, if there was a hard neurologic sign, you could go after that. With the staring spells, you might decide that you want an EEG if you felt like you got a real staring spell history and not just I'm staring off because I'm distracted. And what's a good way to determine if you might want to get an EEG or not in a kid who stares off? What kind of history could you ask? Kind of a quick and dirty question to get to the heart of that.
If he's also having those staring spells at home.
Great question.
Or he's like doing something he actually enjoys.
Sure, staring spell a preferred activity, yeah.
Responsive during them.
Yes, and how responsive to what?
I mean, voice or touch, like if you
Yes.
shake it and he's, yeah.
So voice and touch. So a lot of my ADHD kids are not responsive to voice when they're staring off because they're in their own world. but they should absolutely be responsive to touch every time. So if you go up and you're like, James, he should at least turn when you tap him. If he doesn't turn when you tap him, he needs an EEG for an excellent seizure for sure. So we're gonna assume that we did all that workup, that we tested for learning disabilities, they weren't there, that you know, that he responded to touch and his staring spell, so we're not worried about epilepsy. And so we're to this ADHD picture. We've decided it is ADHD, and if you remember back to our questionnaires, we had 6 or more symptoms in each category. So that would be what type? Excellent job. And so anything else to consider before discussing treatment options? Anything else you guys would want to know?
Any family history of heart disease?
Sure, great question. Specifically, what kind of heart disease?
Okay.
Sure, yep. Or any arrhythmia too. So I'll ask about long QT. I'll ask about any kind of sudden arrhythmias. Now, anytime you ask about an arrhythmia, you get like every 9-year-old in the family with a pacemaker, which is not the history we're going for, but it helps cast a wide net. Another nice cards question is just, did anybody die suddenly without explanation? So like a seizure, somebody who was, you thought maybe it was a seizure, maybe it was, maybe it wasn't. Somebody driving a car and they just suddenly crashed, and there was no explanation, or drowning can be an arrhythmia hidden. So these are all the fun tricks that the cardiologist have taught me. So asking that question, if you really feel like you're not sure this family would give you the information you need, you can ask one of those big wide history questions like that, and you'll get all kinds of information. This was not a fishing question. This was just if you guys were interested in anything else about this kid. So comorbidities are important in terms of treatment, really because a lot of these comorbidities get worse with certain ADHD treatments. Some of the ADHD treatments will make them better. And so we kind of have to know exactly what we're dealing with. That's why we're always screening for these. Comorbidity rates are really high. So more likely than not, you have a comorbidity. If you see our ADHD patients in developmental peds, they all have a comorbidity. That's why they're with us. And so in Gen Peds, you might see some pure ADHD kids, but still about half the ADHD kids managed in Gen Peds are also going to have a comorbidity. So they're going to have a mood disorder, they're going to have a learning disorder, a tic disorder, what else is up there? Yeah, or ODD. ADHD is generally the first presenting symptom, other than ODD, although we wouldn't diagnose it first, probably. We'd probably wait to treat the ADHD to see how that goes first, but you'll see some of that defiant or oppositional stuff sometimes first. But otherwise, ADHD tends to hit first. So even after you've made your ADHD diagnosis, you have to constantly be reassessing to make sure that these comorbidities aren't developing alongside. And so sadly, that the presence of one comorbidity raises your risk of another. So you oftentimes will have kids with multiple of these comorbidities. So maybe a mood disorder, ODD, and ADHD, which you'll see kind of commonly managed in psychiatry and developmental peds. We'll have these big stacks of diagnoses along this line. So you guys already pulled all these out, which was great. So tics, we have to watch out for the tics for him. The ODD you guys were concerned about for sure. The mood symptoms, anytime in any of these cases when somebody starts talking about losing friends, just keep your like spidey sense up that they might be hinting that there's a mood disorder lurking on the test setting. So thinking about that. And then always just adding on for fun, the parents ask, by the way, is he gonna grow out of his ADHD? And what would your response be?
Kids learn how to adapt to their abnormal concentration. Basically, he'll learn behaviors to do with it.
Yeah, so you definitely adapt, but it's always there. Yes, exactly. So interestingly, there is a little bit of shifting with the different symptoms of ADHD over the course of your childhood, which is fun. So inattention never changes, sadly, true. Like the inattention level is always kind of there, even as an adult. Hyperactivity, though, that symptom set tends to decrease over time. So your teenagers with ADHD look more and more like they have ADHD and attentive type than say your 5-year-old or 6-year-old, we'll say 6-year-old with ADHD, who like almost every 6-year-old with ADHD looks like they have combined type. And almost every 18-year-old with ADHD looks like they have an attentive type. Some of that is just how ADHD functions over childhood, but also that there's just kind of some calming that happens in all people over that time. Impulsivity, this is a little bit of a misnomer. It does technically go down over time, but the best curve would actually have it going down and then perking back up again over the teen years and then diving back down in the late 20s. Would be the perfect model of impulsivity. So these are really the reasons we treat. To help decrease school failure, decrease motor vehicle accidents in people with ADHD. Lots of parents are very concerned that they're going to start abusing substances because you're talking about medications that sound like methylphenidate and amphetamine. And actually the studies show that when your ADHD symptoms are well treated, the risk of substance abuse, which is increased in people with ADHD, actually goes down to the standard population risk for substance abuse when your ADHD is well treated. So it's directly related to how well your ADHD is treated. So well-treated ADHD does not increase your substance abuse risk. So that's a really huge reason for parents to be like, oh yeah, my 10-year-old is really struggling with ADHD, let's go ahead and treat it. This kind of sweetens the pot. It's like, oh yes, by the way, it also helps protect them from falling at risk for substance abuse. Higher divorce rates, higher unemployment rates, like there's just a lot of negative prognostic findings in people with ADHD when they don't treat their ADHD. So that's why we treat. And then outcomes are very heavily dependent on kind of all these other external things. Social circumstances, how many comorbidities you have, how severe is your ADHD, these are all kind of logical things one might think. Okay. Just quickly about the AP guidelines. It says updated. They were updated like 18 months ago. So yeah, they're a little old, but they were very updated and exciting 18 months ago. The main thing is that they really encouraged the primary care provider to initiate evaluation for kids all the way down to 4. That was a huge change because many of our pediatricians in the community were trained that they don't look at ADHD until you're 6. And below 6, it's a specialist role. And AAP kind of came out and said, no, you guys can do it all the way down to 4. So we'll talk about how treatment might change in that age group. Unless there are big symptoms of academic failure or behavioral issues, and then they said you can kind of punt them to a subspecialist. They need to meet the DSM-5 criteria. Oddly, that wasn't part of the AAP guidelines previously to that time. And then you are mandated to screen for comorbidities. They just were never specifically named. It just said, go ahead and diagnose with whatever you wanted to use, I guess. And a multimodal approach is always best. That's kind of looking at that age appropriate treatment. So we'd always like to combine counseling with medication, which is hard to do a lot of times in terms of access, but it is possible. So now looking at why we like the multimodal approach in terms of developing a treatment plan. So there is a classic study. It's called the MTA study. MTA is just a shortened abbreviation for methylphenidate because people get tired of writing it and saying it. But it was a multimodal treatment study. And this was just the first of this study has been repeated over and over and over in like this really long longitudinal study over time. And they put people into these 4 randomized groups. One was just community care, which was kind of like choose your own adventure, just whatever the people wanted to do who were treating your ADHD, versus medication plus behavior management alone, or medication alone. And this is really the core of why we recommend the multimodal approach, is that you can see that behavioral therapy by itself is pretty good. Medication management by itself is pretty good. Combination therapy is better. Community-based treatment was a mixed bag. It just kind of depended on what they were doing. They could have been recommending this multimodal approach for all we know. So this was the very first study. Unfortunately, based on this study, people made this assumption that, well, the medication, which was methylphenidate. So methylphenidate looks pretty good, so we don't really need behavioral therapy, we'll just do methylphenidate. Well, as this study's been repeated more and more times, we actually have found that that 60% column for the multimodal approach actually starts approaching 80 to 90% when it was defined a little bit tighter and done for longer periods of time in the 14-month window, which is what this original study was. So we know is that actually over time, that multimodal approach works the very best. So that's why we're always pushing for it. But if you can't get the counseling that you need, yes, methylphenidate by itself is pretty decent. So go ahead and do that in the meantime. But as you guys know, methylphenidate is not the only thing that we have. So we have a whole bunch of medications. And this, we keep using this picture because these are kind of like the ones that Medicaid covers. And so this is the one that you'll see us use the very most. This chart is the methylphenidate chart. I'll show you one in just a minute. That's the amphetamine chart and non-stimulants. This is actually a free download from ADHDmedicationguide.com. And all you have to do is say that you are a medical professional and that you will not sue them if you get sued for a decision you made based on this chart. And it's made by a developmental pediatrician who's just trying to get it out there for all the learners. It gets updated all the time. So every time a new ADHD med comes out, it gets on the chart. So every ADHD medication currently marketed in the United States, so available in the US, will be on this chart. And it constantly kind of shifts and changes. So it's a nice thing to have around. The cool thing about it is that it's actually stacked by dose equivalents. So it's particularly helpful if you're switching from one to the next. So everybody in the third column, all those doses are equivalent doses, which you can tell that the numbers are not always the same. So it is kind of a helpful thing in that sense, particularly with insurance coverage, which with our Medicaid companies switches all the time. And so you do have to switch them from stimulant to stimulant sometimes to keep their coverage going. So they're not paying out of pocket for these. By and large, most of these are anywhere from $200 to upwards of $400 a month for the extended release one. So these are expensive. So you do need to kind of cater to what the insurance company wants. So that's why the chart can be helpful. Yes.
So if you are switching, do you need to lean off with one and then like start slow on the other, like you do with depressive medications, or can you just automatically switch?
Great question. So you can automatically switch. These actually have a super short half-life. So they are pretty much out of your bloodstream by the middle of the night. And so they're not reaching a steady level by any means. And so you can just direct switch. Some kids are a little tearful. It's a little bumpy sometimes when you switch for the first couple days, but it can just be an absolute direct switch. Great question. Yes.
Do you have generics? These or will there be generics that are?
So some. On this sheet, everything but Daytrana is a generic. Because this is the super old one. The newer one is going to have a whole bunch of these brand name, brand only products as well on there. So we mostly work in the world of generics to cater to Medicaid, but they go to generic pretty fast, but they are pretty good money makers. So they do hold out usually the full 7 to 10 years of their patent on all of these. The next one has the amphetamines and the non-stimulants, and we're going to talk about all of these groups in a little bit more detail. On this side, Vyvanse is still a brand name product up there at the top. Just keep it rolling. The non-stimulants though went to generic really fast. They didn't make a ton of money, and so those popped out to generic within just a few years. So it just kind of depends how much the drug company wants to keep it under lock and key. So this is the way that I kind of think about these ADHD meds. Those charts are great for management in clinic, but in terms of conceptualizing this treatment plan, I actually think that this is an easier way to look at it. So for ADHD, we really have these two big main groups, stimulants and non-stimulants. And inside the world of stimulants, we have two groups. We have more or less the Ritalin group and the Adderall group. And each of those comes in short-acting and long-acting forms. inside these groups, there are actually very few differences between the medications in there. So I do not want you to memorize this, but I'm going to show you this just as an example. So the methylphenidate group, Ritalin long-acting, methylphenidate LA is how you'll see it as a generic. It is a little capsule, has beads inside that are coated. Half of them release immediately and half of them release so that they're delayed. It's different from Metadate CD because in Metadate CD, 30% are immediate release and 70% are coded to be delayed release. That's literally the only difference between those two medications. They're both methylphenidate, they're both extended release. Concerta is all immediate release methylphenidate in an osmotic pump capsule. So it continuously releases immediate release methylphenidate out of it. All I'm showing you is that these are all methylphenidates. They just are in different packaging. So you'll see us in developmental peds flip around between different ones because we're trying to like fine tune something just exactly right. But the truth is, about 70% of kids will do great on any stimulant you give them. So it doesn't matter all the style points of which one you chose. You choose the one that their insurance company covers, and 70% of the time you're going to be right. And that's just kind of the way stimulants work. So oftentimes in the community, you'll find many of our general pediatricians pick like 2 or 3 stimulants that they feel super comfortable with, and they use those. And when they run out of trying each of those 2 or 3 that they like, then they say, this is a hard to manage kid with ADHD, they probably need a subspecialist. And that's a perfectly reasonable approach to doing it. Inside the world of amphetamines, we really have 2. We have Adderall, which is mixed amphetamine salts, and then we have Vyvanse or lisdexamphetamine is its generic name. And again, I'm highlighting the ones that we have really broad coverage for in South Carolina. There are fancier versions of all of these. There are chewables now and all kinds of other things. But these are the ones that you can readily get insurance to cover. Stimulants in general target all 3 symptoms of ADHD very well. So inattention, hyperactivity, and impulsivity. They're designed to cover school hours. So they're all somewhere usually between 6 to 12 hours of duration. So for a younger kid, you might pick one that's a little shorter. For an older kid, you might really need the 12-hour coverage of like Concerta or Vyvanse, which are the 2 longest lasting. Side effects, you guys probably know some of these. Spit out some of these stimulant side effects. Yeah, appetite suppression is a big one. What other ones? Tics, yep, worsening of tics.
Insomnia.
Yep, sleep, insomnia. High blood pressure, yep.
Stomach aches, headaches.
Yep.
Mood.
Oftentimes anxiety. Could do depression, but yes, mood in general, but most often anxiety. So if you get an anxious kid and you throw them on a stimulant, sometimes they get real anxious real fast. Excellent. Those are the big ones. Hallucinations are possible. That's kind of a fun one to throw in there. Most often formication, so the feeling like bugs are crawling or seeing bugs crawl. You don't see it. Yeah, you don't see it very often, but it does pop up. So then we'll shift over to looking at the non-stimulants. And in the world of non-stimulants, there are 2 kind of groups. So the alpha agonists, and then there's atomoxetine, or Strattera. And alpha agonist, the most common one that we use is guanfacine. It's a little bit less sedating. It comes in an extended release form, so it can have once a day dosing. I think most people are more familiar with clonidine because it's used so heavily for sleep as well. Clonidine during the day, though, tends to just keep knocking kids out. So they'll fall asleep and then they'll wake up just as wild as they were, and then they'll fall asleep again on the next dose. They'll wake up wild. So it's very up and down during the day, which is why you oftentimes see us flop over to guanfacine in its place. The alpha agonists and non-stimulants are mostly targeting hyperactivity and impulsivity. So that's what it's the best at getting after. They really cover 24 hours a day. Most of those stimulant side effects that are the reason we don't want stimulants to work all the time, like you can't fall asleep and you can't eat, those are mostly kind of tied to treating the inattention part of ADHD. So with the non-stimulant, you're not going after that specific group. And so you actually find that they help kids sleep, they tend to chill out anxiety. So they have a really kind of nice, mild approach to ADHD while also not worsening insomnia usually, not usually worsening anxiety. But they don't have the power there to like really make attention span get better. So it's a little bit of a trade-off. I was gonna say one other thing there. Clonidine does come in an extended release. It has very kind of rare times when it's useful, although it can be very useful. But usually in a kid with a lot of comorbidities like autism and intellectual disability and really impressive hyperactivity. Yeah.
Sorry for all the questions.
No, I love it. Please
Is
do.
Wellbutrin not recommended anymore for ADHD?
So it's not on label for the treatment of ADHD in any age group. So these are all on label for the treatment of ADHD.
And guanosine is technically like a blood pressure.
It is an old blood pressure
Right.
medication.
Does it have a lot of effect on blood pressure or not really?
So clonidine tends to do more of it than the guanfacine does. Guanfacine is a little bit steadier release. It actually was designed as a blood pressure medication and it wasn't great at it. And so they really kind of stopped marketing it in that direction, but they realized that it made it really chill people's ADHD out. And so it kind of pivoted toward being more of a behavioral medication. The extended release form, Intuitive, is not a blood pressure medication at all. It is FDA approved for treatment of ADHD, very specifically. So it's really shifted into an ADHD med, but clonidine is still used for blood pressure, quite a bit, so. And then lastly is our love-hate relationship with atomoxetine. So atomoxetine is kind of the outlier here. It was supposed to be really lovely at helping anxiety and ADHD together, which oftentimes run together and are hard to treat together with one medication. So this was going to be the be-all end-all. We were all so excited. Yay, atomoxetine. At the end of the day, it very rarely ever works for ADHD at all. Tends to cause a lot of really bumpy mood swing side effects as you come onto the medicine. Those settle down after like 6 to 8 weeks, almost like an SSRI. But most parents don't hang in there that long. There have been some really interesting small studies here of late showing some improvements in dyslexia, even when you don't have ADHD, which is kind of an interesting thing, but that's not a clinical recommendation yet. So by and large, you will not see us use atomoxetine very often, unless we actually have a true contraindication to stimulants. Like we've got a kid who's like status post-Fontan, and we just are not going to challenge that heart to not have any abnormal rhythms in it now that we've operated on it 70 times. So we do have a few kids like that. So we will try atomoxetine in them almost like as a last ditch effort. We used to see a lot more people in the community using it. Now we rarely see kids come in on it either. So it's there. They love to ask about it on tests. They just love it. But we just don't use it very often. Mainly just that it's a non-stimulant medication option is mainly the question they like to ask about it. I think it'd be mainly because at that time, the alpha agonists weren't on label for ADHD when many of these questions were written. So atomoxetine was approved for ADHD before they were, and so it was for a while the only one. Oh, so see, I stayed on that slide, but I have these other slides to wait for, right? And so this just tells you a little bit more information about stimulants, which you guys can feel free to review at your leisure. And we talked about stimulant side effects, which you guys nailed straight through. They're the back of the Vanderbilt. So if you ever get confused, just take a look at the Vanderbilt because that's where they all are. One thing that we didn't mention much was rebound as a side effect of the stimulants. So when the stimulants wear off, it can be a bumpy drop for some kids, a precipitous drop of medication, almost like getting a rug pulled out from underneath them. So you can see rebound hyperactivity, which is what we would expect. Suddenly their ADHD just comes back. But some kids will have really significant rebound irritability. And so they'll be crying, tearful, seeing more oppositional, more defiant, more tantrums. And oftentimes parents will, that hour or so as the medicine wears off will be so prevalent to them in their head that they will come in and tell you the history is you started my kid on this medicine, but we're still seeing tantrums and we're still seeing all these issues. And that's how they'll describe it to you. Just we're on the medicine and we're still having problems. And so based on that history, what would you probably do as your next decision? You'd increase the medicine. And I'll tell you, everything will get worse. So what you really have to ask is if they say, and we're still having tantrums, we're still having issues, what time of day are you having those issues? Because if you're having those at 10 in the morning, yes, we're gonna increase the dose. If you're only having them between 3 and 4:30 in the afternoon every single day, and it's always at the same time, then whatever we do, we don't want to increase that medicine, because that's gonna get worse. We probably need to switch to something different. Or we could find that our dose was actually too high and we needed to come down a little bit. But so timing, when you're taking your history, when you're modifying your treatment plan, timing of symptoms becomes really important, because you have this medication that you know only works for 8 hours. And so anything that's happening at the same predictable place, like always as the medicine wears off, that's probably related to your medicine. And so you can need to adjust it a little bit. Do we have any questions about rebound?
If you do like does it make a difference if you switch classes? Like, will one do it more than the other for some patients?
For some kids, yeah, it's unpredictable who's gonna respond to which one.
And even like switching within the same class can sometimes fix it.
It can definitely sometimes fix it. The ones that are the best at not doing rebound are our longest acting ones, so Concerta and Vyvanse. And what does Concerta look like as the generic? It's like methylphenidate. Ooh, and I'm trying to think in our EHR how it pulls up. Just search it as Concerta and it's gonna convert it to the generic, because they're all methylphenidate. So if you just type methylphenidate in, you get all of the methylphenidates in one list, and it's very confusing. So this is the time you're gonna use the brand name, just so you can get to the right generic that's in there. But Concerta and Vyvanse, both because of how they're engineered to work, they actually rev up slowly and then they come down slowly. And I'll show you what I mean by that in just a minute, because I've got a nice slide of it. Oh, it's right here. Perfect. Great question. So this is just comparing different, these are all methylphenidate. So the medicine in all 4 of these medications is identically the same. We're just looking at delivery system, okay? And what we're looking at is based on their delivery system, when does the coverage spike, or when does the blood concentration of the medication spike? So the first one we're looking at is Ritalin 20 twice a day. So this is just short-acting methylphenidate. Lasts about 3 to 4 hours a dose, and it's that yellow line. So you see it spikes up the first time, then we gave a second dose before the spike had totally gone down. And so it spikes up even higher on the second. And what we really notice is how we took that beautiful precipitous drop, right? From the top of the yellow down to the bottom. So that is particularly hard for children to deal with. It feels like they just drank a ton of caffeine or something and it suddenly all just wore out at once. So that's when you're going to find rebound symptoms. So all these fancy extended release ones are there to keep you from having to take a dose of medicine at school and to keep that drop from happening. It's kind of all style points at that point. So Concerta is this capsule, I told you, it sucks in water on one end and then slowly pushes it out the other end, really fancy. And you see how it's much smoother, that hot pink line, how nice and smooth it kind of ramps up and it comes up and it comes off nice and smoothly. And then Metadate CD, that's the one I told you was 30% immediate release and then 70% extended release. And you see it's really nice and smooth as well. It kind of comes in a little bit faster than Concerta does, and you sometimes will see that clinically in a very sensitive kid to these medications. And then lastly, you've got the Ritalin LA40, and that's the one that's supposed to be kind of 50-50 split. You see it has a little spike and then it goes down. Not too different from the Ritalin 20 twice a day, other than that Ritalin has a big dip in the middle. So the truth is in actuality, most children don't feel any of these changes between these medications. Like these would all, for the most part, clinically look the same for them. But in a sensitive kid, you'll see a difference one to the next. So that's the reason why you see us switching between meds sometimes. But if you were in Gen Peds and you decided, you know what, Metadate has really good coverage right now, it seems to work really well, you could just probably manage almost all your patients on Metadate by itself. And when you hit one that didn't do well on that medicine, you would just kind of bump over to some backup. What we usually do is we try 1 or 2 methylphenidates, and then we switch over to the amphetamine class. Mainly for us in developmental peds, we do that because our younger kids tend to tolerate methylphenidate better than the amphetamines. But you'll see some people lead with an amphetamine salt. There's really not a right or wrong.
Will you talk about when you change meds dropping down like one dose versus when you change classes? And
Yes.
why you'd go down a dose versus do an equivalent dose?
Sure, that's because you worked with me too much. So I'm a pansy sometimes, and if I know one medication is a little bit more powerful than another one, sometimes you'll see us drop a dose down. So let me go back to that equivalent chart and show you what we're talking about. So we'll look at this chart. So the methylphenidate chart. Let's say that I had a kid who was on Metadate CD 30 milligrams. But it's wearing off at like 2 and they need to do homework when they get home. So we need like 2 hours of extra coverage. This is like the story of my world. So they come in and they give it at 7, it wears off at 2, but they have homework or band practice or I don't know what they've got, karate until 4. And so we really want it to wear off at 4:30, not at 2:30. So what are we gonna do? So Metadate lasts about 8 hours, more or less. Concerta lasts longer. So maybe we would say, okay, well, can you swallow the pill whole? Sure. Okay, well, let's try Concerta instead. So the equivalent dose would be to go from 30 to then 54 milligrams of Concerta. But every so often when you switch from one to the next, particularly if in your head, so Concerta tends to sometimes be a little bit on the powerful side. So I would probably take that kid down to 36 milligrams of Concerta and tell the parents, call me in 2 weeks if it didn't work, and then go up to 54. So sometimes we'll do that. But I'll tell you that like if I was switching from Concerta to Metadate, I would always just go down to the equivalent because Metadate's probably a little bit weaker, if anything. But for the most part, you can do a pretty direct switch, but if you're worried about it, you just go down 1 dose on this equivalent chart. Did that answer your question?
Yes, and it shouldn't, like, it doesn't matter if you're going from a methylphenidate to an amphetamine, like, it's still the same story.
Correct, especially like switching between Concerta and Vyvanse. So if I was gonna take, let's say that the kid's on 54 of Concerta and we don't feel like it's working very well. So Concerta in terms of the big columns, 54 is the 3rd column. Don't be tricked by the 27, that's an intermediate dose, which is very useful, but for equivalence, we're just gonna skip to the ones that have the big full lines of medication. So you'd say like 54, that's kind of like the 3rd column. If you wanted to switch to Vyvanse, you'd switch your chart over and you'd go to like the 3rd column. So you would say maybe 40, 30 to 40, somewhere in there, just depending on whether you felt like the kids' symptoms were well controlled on the previous dose or if they needed a little bump up. So.
Okay, yes, thank you so much.
Welcome.
So then a lot of those extended release ones, they can't be like broken up or crushed or anything, right? So correct, there's certain one, like the younger population, if they can't swallow pills, you're gonna be super limited on what you can give them.
You're quite limited. Yes, so they are working on that. So the ones that aren't on your chart, on this chart. Vyvanse now comes in a chewable. Vyvanse you'll see is actually used a lot of because you actually can open Vyvanse's capsule up and inside of it is a powder that dissolves clear, tasteless, and odorless into water. It sounds very sneaky, and it is. But so you can get it into a lot of kids that way. So that's why we use a lot of Vyvanse. But Vyvanse actually comes in a chewable now, and that chewable is actually covered by like 3 of our 5 MCOs for Medicaid now. So you actually there's a fair amount of coverage on it, oddly. And there is a liquid extended release methylphenidate named Quillavant XR that is very hard to find in the pharmacies, but it works. Probably still, it's advertised to work a really long duration like Concerta, but we find that it really probably works 6 to 8 hours. So it's kind of more of the intermediate ones like the Ritalin LA and Metadate CD.
There's Quilla-Chew too.
And Quilla-Chew. Quilla-Chew has about the worst rebound irritability of anything I've seen on the market. That being said, most kids don't have that side effect with it, but when they do, it can be impressive. It's similar to like the anger that sometimes you see on Singular for kids. If you've ever seen Singular give a behavioral side effect, it's similar to what you see on Quilla-Chew for whatever reason. Who knows? They're both chewable. I don't know. It's something to make chewable. I'm not sure. Any other questions about this kind of shifting between that?
What would, like, I know sometimes we'll have them like take a dose at lunch.
Yes.
Like, how would you choose between doing like that kind of regimen versus one of the longer acting ones?
Excellent. So I always do longer acting when I have availability to do it, because there's just some stigma of having to go to the nurse to get your dose of medicine at school, and so we try to stay away from that as much as we can. That being said, that's not always possible. So you may have a kid who can only be managed on well, let's say Adderall, since that's the sheet we're on, who can only be managed on Adderall XR, but it wears off, after 5 hours. And so they get it at 7, and then by noon, they need something. And so we decide we're gonna give them a booster dose. And so how we decide what dose that is, if they are on, you have whatever their continuous was, their extended release was. So if you're on 10 milligrams of Adderall XR, your booster dose is gonna be 5. And that's actually how the Adderall works. It's 50-50, so you're just extending it. So what you're really trying to mimic is 5, 5, 5. So you give 10 of the extended release and 5 of a short acting at the end to try to get it as smooth as possible. Sometimes if we're having a lot of rebound irritability, we'll actually try to taper them off the medicine through the day. And so we would do like a 10 milligram in the morning, extended release, so it's like 5 and 5, and then we might do a booster dose that's only 2.5. And for some kids, that actually gets rid of the rebound irritability because they come off the medicine nice and slowly. So always kind of thinking about that chart, and this chart, and trying to think, how can I make this chart as smooth as possible? We kind of live in the world of pharmacokinetics and pharmacodynamics a lot because these medicines are quick acting, so you can manipulate them pretty nicely if you kind of can understand how they're working and how they're spiking and how to smooth it out. But that's the idea behind the booster dose.
Does it also help with like appetite? Because I know sometimes if kids aren't eating lunch, sometimes they'll try that. Does that work very well or not really?
It works. It's always worth a try because I'm surprised by who it works for and who it doesn't work for. In other words, it's fairly unpredictable. But yes, some kids will do fine on the immediate release twice a day, and then they absolutely need more on that because the medicine dips, and then you just have to time offering them food in the dip, which sometimes if they're at school, it doesn't hit at the right time, so it's unhelpful. If it hits just right, then yes, they'll eat their lunch and they'll not have weight loss. So if you're having issues managing weight on an extended release, that is the traditional advice, is to go back to short acting and do multiple doses in the day. Good question. What else we got here? Okay, let's look real quickly at the, there we go. Real quickly at the non-stimulant medications, because I think that this is one place where we do something a little bit different than you usually see in Gen Peds, which is when you come and visit us in developmental Peds, we commonly are running kids on 2 ADHD meds. We commonly have kids on a non-stimulant and a stimulant together. This is kind of like our classic developmental Peds twist. And what we're really trying to do is control hyperactivity and impulsivity throughout the day. And then we're trying to help manage attention even tighter during school hours. So you will often combine like guanfacine extended release with a stimulant on top, whichever stimulant you want. The side effect profiles of these two groups are actually really nice together. They play nicely together. So stimulants can raise heart rate, raise blood pressure. Non-stimulants lower both of those. Stimulants decrease appetite, and non-stimulant is either neutral or increases appetite. Stimulants make it hard for you to fall asleep at night. Non-stimulants make it easier for you to sleep at night. So a lot of the main side effects get balanced out. The only overlapping side effect is irritability. And irritability on the non-stimulants like guanfacine, it increases with your dose, and it's kind of sneaky and it develops kind of over time. So you have to constantly be watching out for it. But when that irritability hits, it will be all the time irritability, 24 hours a day irritability. Very different from the stimulant, because if you're going to get stimulant irritability, when do you most commonly see that? Usually at the end, when it's wearing out, or right when you first take it, if you really picked a really high dose, As soon as they take it, it kind of hits and they feel terrible and then they're a little better. But so it's start and ends of doses. But we use those together quite often, and you even see it's listed there. So you can use it as monotherapy or adjuvant therapy. And the common side effects are kind of the sedation, being a little sleepy, being a little dizzy, and headache. That's the other kind of duplicate side effect between the two groups to watch out for. But you see us, you guys will see us use fluoxetine like all the time for everything in almost every circumstance. It's because it's generally well tolerated and oftentimes does a lot more than we give credit for. Atomoxetine we talked about, we just don't use very often, so. Okay, so for this little guy, James, what would your kind of go-to first thing be? So he's an 8-year-old, we'll assume he's in 3rd grade, so you kind of have an idea about his school day. Probably has some homework, but probably not 6 hours of essays and whatnot from high school. What would you probably think it would be a good first step for him?
Starting dose of Concerta and BMA.
Fantastic. Yeah. If you could have thrown out any stimulants you wanted, I wouldn't have cared which one y'all said. That's the right one, yes. During Focalin XR, which is real short acting, only lasts about 6 hours. So that one probably would have been my first. But yes, any of these nice long acting ones. Concerta you may find is a little too long for this kid, just depends on the kid. So you may then backstep and say, okay, well, let's just do methylphenidate LA. It's a little shorter acting, something like that. But whatever his insurance company covers, and then some either BMOD or even like traditional counseling, like CBT, would be kind of on the young age for, but you could probably push him in there. They could work on organizational skills, oftentimes mood regulation, the oppositional type behavior, they could do all of those. If symptoms persist, what could you do? Like, so if you start them on that starting dose, they come back a month later and they say, we don't see any change. Yeah, so the first step is to increase the dose of the same medicine. We only switch when we either have maxed out the dose, which is rare, or if we have a side effect that's in our way. Otherwise, if they're tolerating the medicine fine, but you still have ADHD symptoms, you stick with the same med and you just keep going up and up and up and up and up until you hit either the desired effect or a side effect. And I usually tell parents that right at the beginning, so they know for the next 3 months, you may see me once a month and I may increase this kid's dose every single time, and do not be alarmed by that. That's how these medicines work. That's an okay thing. Otherwise, they're gonna get real nervous with you doing that. I also warn them that your kid may be the kind of kid we have to switch through 3 different stimulants to find the one that doesn't have all the side effects for him. And that's also okay. Just kind of prepping people for that is good. And I gave it away. What if side effects emerge? Yeah, then we would look at switching. If you run through a few different stimulants and you can't find the one that fits, that's when you may think, well, maybe I need to add a non-stimulant in there. Maybe I should add guanfacine and see if it can help kind of take away some of the ADHD that we're dealing with all the time, and then help us do a lower dose of a stimulant that the kid can tolerate. So it's one other kind of way that you can kind of get around side effects. That's usually only after you've tried a few stimulants to see if they can't be managed on a monotherapy first. And in terms of measuring outcomes, the Vanderbilt, follow up, use it, embrace it, love it, manage your side effects. This is why it's helpful to add the total number of symptoms, like not up to 18, but out of 54, because then you can see that number drift. So if they came to you and they were all 3s on all 18 symptoms of ADHD, they would have a score of 54. And then just trust me. And I can only add to 54. And then you may see, a month later that it's down to like 48. And then the next month after you've made another dose change, then maybe it's like 35. And then you may say, ooh, this is great symptom reduction, right? We went from 54 to 35. That looks pretty good. And so you can use that overall number. Very often though, what I find people do is they don't take the time to add up that total number. And you may never see a lot of movement in your number of symptoms because they may just go from all 3s to all 2s. And then you would still say that they had 9 and 9 of the symptoms. Does that make sense? So if you're running a total score, you can see better, more subtle changes. So it's a little better for tracking that total score number. And AAP says if still after all of this great management you guys have done, they're still not meeting their goals, then go back and look at your original diagnosis. Make sure it really was ADHD. Make sure there's not a mood issue. Go back through all of the comorbidities. Make sure there's not something else in the way. Very often, make sure they're giving the medicine. Make sure that it's been filled on scripts. Like make sure that it's good getting into the kiddo, and making sure that they're going to behavioral therapy. Oftentimes we are treating ADHD really nicely, but we still have a ton of oppositional and defiant behavior. The medications don't treat ODD, they only treat ADHD. You've got to have the therapy to get the ODD symptoms out of there. And that's it. There are a couple of resources. There's like some AAP cool ADHD guides that a lot of general pediatricians use. And the non-medical treatments are varying in their popularity, but in general, they all lack enough support to be recommended.
Just wondering too, so let's say like a patient or a girl like has comorbid symptoms like anxiety, depression on top of ADHD. Would combining like doing the two medicines, having those two medications, do you think that would help the comorbid conditions in the sense that it's actually not treating the comorbid condition or just kind of just bolstering the ADHD part that then prevents the comorbidity?
Yeah, so guanfacine has a little bit of an anti-anxiety effect. That's why we like it so much. And so it does not treat anxiety. Like if you have an anxiety disorder, guanfacine is not going to do anything to help it. But if you are a worrier and a little bit anxious and you have ADHD, oftentimes guanfacine will take care of that much anxiety. At least bring it down to a manageable level where then they can manage it with counseling. So it's a great kind of tool to use. But you will find that we have a lot of kids who have true anxiety disorders and ADHD, and they actually end up on a combination of a stimulant and an SSRI. Kind of a different direction. Any other questions?